Welcome to today's virtual education event on endoscopic luminal stenting presented by Dr. James Tabibian. Dr. Tabibian completed his medical degree at the University of California, Los Angeles and residency in internal medicine at Johns Hopkins. He then went on to complete gastroenterology fellowship as well as postdoctoral PhD training at the Mayo Clinic, followed by an advanced endoscopy fellowship at the University of Pennsylvania. Dr. Tabibian is an associate professor in the Geffen School of Medicine at UCLA and currently serves as the director of endoscopy at Olive View UCLA Medical Center, performing a wide range of advanced therapeutic procedures. Today, Dr. Tabibian will speak about endoscopic luminal stenting, highlighting recent clinical trends, procedural techniques, and stenting options available in the U.S. Dr. Tabibian, welcome and thank you for joining us. The floor is yours.
Thank you very much. I'm excited today to discuss with you all some advances in the field, and in particular to provide an overview of endoscopic luminal stenting focused on self-expanding metallic stents, or SEMS, and practical clinical updates relevant to the advanced endoscopy team. So thank you everyone for joining in, and let's get started. So in terms of trends in luminal stenting, in the 21st century, SEMS are increasingly used for a variety of indications. They can be deployed in various locations from the esophagus to the rectum, and they're available in a broad variety of flavors or genres, each with their respective uses and characteristics. On the right-hand side are a number of different stents, for instance, that can be deployed in different parts of the alimentary tract and biliary tract. So the indications for GI luminal stenting are primarily malignant luminal obstruction, be this in the esophagus, the duodenum, the colon, or the biliary tree. There are many considerations in potential SEMS cases, and I tend to think of these as case-specific and also SEMS-specific. With regard to case-specific considerations, the first question I ask at a very high level is, or I think about at a high level is, are there any contraindications to SEMS placement? For example, is there already spontaneous perforation of a colonic tumor, for instance? I also think, well, what are the alternatives here? Let's get them all on the table. For instance, surgery, interventional radiology techniques, radiation, or otherwise. I then also think about what is the likelihood of technical and also clinical success were I to place a SEMS here. And there are many variables that go into that question. These include, for instance, is there adequate space proximally and distally to house or to accommodate a SEMS? So, for example, this may be a particular area of concern for in a case of a proximal esophageal tumor. Conversely, you would worry about, or one might worry about, space distally in a very distal or low rectal lesion. And so it's important to review the anatomy, the imaging, and gather these tidbits, these important factoids a priori in assessing whether or not the case is appropriate for SEMS placement. I also think about futility concerns. For instance, if a patient has multifocal small bowel obstruction, the placement of a duodenal SEMS, even if it's in the second or third or fourth portion, is not going to resolve a locked bowel due to peritoneal carcinomatosis, for instance, with multifocal small intestinal obstruction. It would be just the tip of the iceberg. And so in those instances, SEMS placement, even if technically feasible, may not be likely to result in clinical success. Similarly, if a patient has already an extremely poor prognosis and the expected survival is very short, a SEMS becomes a difficult ethical consideration or scenario, and the risks and benefits and alternatives should be very carefully discussed with the patient and all the relevant stakeholders. Lastly, as far as the short list is concerned, I think about what is the likelihood of and what are the types of adverse events which might occur in this particular case with SEMS placement. And not only what is the likelihood and what are the types, but what would be the impact in this particular case? And what would it take to resolve that issue? For instance, would I be able to close, let's say, a perforation endoscopically, or would this require surgery? And if it requires surgery, is the patient even an operative candidate? Does surgery know about this patient? Are we making a decision all together for a given scenario? With regard to SEMS-specific considerations, the question of which SEMS to use for a given case comes up not infrequently and is actually a very important and involved question. So let's talk about design considerations with respect to SEMS. As the audience will appreciate, not all SEMS are created equal. There are many differences in SEMS, not only between different anatomical regions, esophagus, duodenum, colon, biliary tract, as illustrated in the image to the right, but even within a given anatomical region, there are many differences within or among SEMS. And part of this stems from the fact that there are various manufacturers. Each manufacturer may have more than one SEMS as an option for a given anatomical region or location. And periodically, there are new SEMS that are being introduced into the marketplace. And so it really is an evolving and exciting field. This is perhaps one of my favorite slides, though it is a bit busy, and it's my favorite in part maybe because of the illustration on the right. But I want to express to the audience that there are many, many SEMS characteristics to consider. And in random order, I'll go down the list here. The first that comes to mind is composition. What is the stent actually made of? Is it made of nitinol, platinol, or some other material? And also, is it covered or not? And if it's covered, is it fully covered or partially covered? Those are options that exist in certain anatomical locations, but not all. What is the construction of the stent? So aside from its composition, how was it actually put together or manufactured? Is it laser cut? Is it woven? Is there a hook and cross feature? These are, to some, may seem like minutiae, but they are actually important considerations and have important potential implications. The third characteristic that I think about is what are the unconstrained dimensions? So by this I mean I'm referring to the various length and diameter or size options. I want to know also what is there a distal or proximal flange, and to what extent is it flared? And does the stent foreshorten once it is deployed, and to what degree, and what are the determinants? The next characteristic is the delivery system, and in general, these can be categorized as either through the scope or TTS or not. And so, for example, for esophageal stents, both of these are now options. And for the biliary system, for instance, we really only place through the scope stents by and large. The fifth characteristic here is the radial and axial forces, which I'll get into more in a subsequent slide. These are not the same thing. They are very different, and both are very important. And they should be considered, and the endoscopist should have an understanding of how each stent or SEMS compares with regard to these two force types. Now, characteristic number 6, ease of use and whether or not there is good deployment control. You really want a device that is easy to use, or if it's not easy to use, you at least want to be comfortable using it, even if it's complex, so to speak. And you want to have a deployment system that has good tactile feedback, it's smooth, one that performs reliably time and time again, rather than one with unpredictable jumps or one that may perform in a way that was not anticipated during the procedure. Another important consideration here, which perhaps we don't think about or discuss enough, is cost, the price of the stent. And I'll come back to that in a subsequent slide as well. But know that there are differences between manufacturers and even within manufacturers with the different SEMS options that are available. There are many other characteristics to consider as well, and among those are any anti-migration features that a stent may have, and also any features that may impact or facilitate future removability. So I tend to reflect on SEMS characteristics quite a bit, and I think that is important. It's really to try to ensure the best outcome possible for the patient. And there are several SEMS characteristics from the prior slide that are actually interrelated with each other. For instance, the construction of the stent affects its axial force, and another example would be that the composition of the stent affects its radiographic visibility. So there is some crossover, if you will, in stent characteristics that should be considered prior to selecting or upon selecting a SEMS for a given case. And as I may have alluded to before, not all providers or advanced endoscopy teams fully consider SEMS characteristics. It's easy to overlook important implications as well as comparative advantages of one SEMS over the other. So for instance, radiographic visibility can impact the degree of placement precision and also future treatment determinations. The radiographic visibility, in my experience, is particularly important in obese patients in whom the fluoroscopy or X-ray beam may not penetrate as readily. It's also important in the perihilar ductal system because of the intricacy of the anatomy, its 3D nature, and the importance of not isolating one branch when trying to open up an adjacent branch. And it's also particularly important and can be challenging in large bowel obstruction or colonic obstruction cases where the large amount of air really impedes radiographic visualization. And therefore, having a stent or a SEMS with excellent radiographic visibility or useful markers is quite critical. A second characteristic that may be underappreciated is axial force. And it's important to know that a relatively high axial force of a SEMS can make it less comfortable for the patient and less conformable to the lumen of wherever it's being deployed, duodenum or rectum or otherwise. And this decrease in conformability can predispose to both tissue overgrowth as well as SEMS-related pain. And these have actually been studied and published upon in some of the citations that are shown at the bottom of the screen. A third characteristic, which I think can be easy to overlook, is cost. And I'll say that at some point and to some degree, cost circles back to us, whether this is in our taxes, our health insurance premiums, or otherwise. So I think it behooves us to be conscientious, not only at an individual level, but on really a overall public health or healthcare system level, and to make decisions carefully. So in this slide, I've shown, or I show the HANAROSTENT family of SEMS, of self-expanding metallic stents. And as you can see, there are a broad array of options from which to choose. I've made some annotations here to the various stents, but going from the bottom left and in a clockwise fashion, we have the HANAROSTENT esophageal through the scope stent, which is available in 10 sizes. Next is the over-the-wire HANAROSTENT esophageal stent, available in 8 sizes. Next is the HANAROSTENT biliary stent, available in 13 size options. And then we have the duodenal and the colonic HANAROSTENTs, both of which are available in several sizes. In my experience, the HANAROSTENT family has several comparative advantages over other available stents. And some of these I think are particularly important, and their importance may depend on the particular case that may be before you. And the three comparative advantages that I'd like to focus on are the radiographic visibility, which is in large part due to gold markers that are incorporated in the stent. More to come on this in just a minute. The low axial force of the HANAROSTENT family, and also the relative cost, or the low relative cost. Other advantages, which I won't go into in detail, are the array of size options, which the previous slide helps allude to, and also the tactile feel and smoothness of the deployment system. Recognizing that every deployment system has its nuances and may be different, but once you get to experience this deployment system, I think most people feel that it is very predictable and performs well. So I'd like to really emphasize the first 2 points here, the radiographic visibility and the low axial force, in the forthcoming slides. So comparative advantage 1 is the enhanced radiographic visibility, and this is in large part via 12 gold markers, 4 at one end, 4 in the middle, and 4 at the other end. And this is illustrated in the top left image, which I took with my iPhone, I believe. And to the right is a beautiful illustration which was provided to us courtesy of Olympus and HANAROSTENT. And on the bottom left here is a case of mine from not too long ago. The yellow arrows are pointing to the proximal 4 radiopaque gold markers, the blue, the middle 4, and the white arrows, the distal 4. And these are very nicely seen, very easily seen, as well as the body of the stent, for that matter, on this real-time fluoroscopic image. Here's some more examples here of the enhanced radiopaque visibility. On the left is a case of both biliary and duodenal obstruction. And the audience can see that there is both a duodenal stent here with its 12 radiopaque markers, 4, 4, and 4, and also a biliary stent with its respective markers. The markers are very easy to see, and they delineate the proximal and distal ends as well as the middle aspect of these stents. A very similar case is seen adjacent to it on the right-hand side. And again, actually, I'm sorry, this is the same case. The image on the left is the real-time fluoroscopic image immediately after deployment. And then on the right is a CT topogram taken a couple days later, where you can see the biliary stent has nicely expanded and the waist in the middle portion has essentially completely become effaced, indicating a therapeutic effect. Comparative advantage number 2 is the low axial force of this stent. And here I have a variety of images. On the top left is a photo of a fully covered HANAROSTENT. On the bottom left are some images of how these stents actually undergo benchtop testing to measure their axial and other forces, radial or other properties for that matter. And the low axial force is really in large part due to or facilitated by this cross and hook design, which is shown on the upper left of the image on the right, as compared to the traditional cross design only, which is shown on the upper right. And the hook cross structure, which is unique to HANAROSTENTs, allows for I think an ideal balance of performance characteristics. The cross allows the high pushability through a catheter, which we want. We don't want the stent to buckle or the system to buckle. The hooks provide flexibility to conform to the anatomy at hand. And on the bottom right here is a zoomed in photo showing a cross in the red circle and a hook in the light blue circle. And then to the right of those, you can see the gold radiopaque, one of the gold radiopaque markers. I have a few illustrations here of the low axial force in play. This is here a case of a lady with metastatic ovarian cancer. Her stomach is diffusely thickened. There is a tumor invasion. The gastric lumen is very narrowed, very irregular, and you can hardly see a duodenal lumen in where there's one bubble from the duodenum on the upper left of the image. And so in this case, we elected to place a HANAROSTENT. It's a relatively long stent given how long of a stretch of lumen was compromised. And here you can see the distal 4 radiopaque markers very nicely, very clearly. And here's the stent deployed. This is an immediate post-deployment fluoroscopic image. And again, the 3D conformity is very easy to appreciate here. And also the stent expansion, the rapid expansion is also notable. And this patient did very, very well with this stent placement, and to our satisfaction, she did not complain of any post-procedure tumor expansion-related pain. So it really was a win-win in terms of establishing patency without causing undue discomfort. Here's another case which shows, again, this is a CT topogram on the left, but nice confirmation and excellent radiopaque visibility of a duodenal HANAROSTENT. A different case on the right-hand side. This is from an X-ray, again showing nice curvature, nice confirmation, or conformity, I should say, and very easy visibility, which is what we want. Here's perhaps my last image here for this presentation, but this is a very interesting case of a patient with gastric cancer who had a gastrojejunostomy performed for decompression that did not go as planned, and so he had a few stents placed to try to open up his alimentary tract and allow ingesta to go through uneventfully. In the middle of the screen, you can see a HANAROSTENT, easy to spot, very clear radiopaque markers at the ends and in the middle, and you can see that it adjusts or conforms to the luminal anatomy. On the lower right is a different stent, which, though it has expanded as we would like, you can see that it really seems to maintain a tubular structure without necessarily conforming to the anatomy of the bowel here. And in some cases, that lack of conformity can be problematic, as mentioned earlier. And so I thought this was a nice case where two different stents are within one patient, and you can kind of appreciate the different features of each stent. That is all for my presentation for today. I hope this was a light and refreshing presentation, but also similarly, or at the same time, comprehensive and clinically useful. And thank you for tuning in. Appreciate it very much.
Dr. Tabibian, thank you so much for your time and sharing your insight on endoscopic luminal stenting trends. For any questions regarding HANAROSTENT, please reach out to your local Olympus representative. With that, this concludes today's presentation. Thank you for joining us.
Thank you.